Hello everyone, I am Dr. Mythri Shankar, Assistant Professor in Nephrology from Institute of Nephrology, Bangalore. I'll be talking to you about pharmacokinetics and chronic kidney disease today. So here is the brief overview of my talk, introduction and challenges that we all face in prescribing medications in chronic kidney disease population, general principles of pharmacokinetics, impact of chronic kidney disease on pharmacokinetics, how do we quantify GFR, and basic principles in prescribing to patients with chronic kidney disease. We are all very well aware that the prevalence of chronic kidney disease has been increasing, and patients with CKD, patients on dialysis, have several comorbidities like diabetes, hypertension, coronary artery disease, and anemia. To control these and other comorbidities, our patients are on an average of 12 different medications with a median daily pill burden of 19. So, as a consequence of this polypharmacy, they are at a very heightened risk of medication related problems. And it has been reported that there is one medication related problem for every 2.7 medication exposures in dialysis patients. Also, dosing errors occur at an alarming rate. So, the challenge is that there is limited pharmacokinetic data available for patients with kidney disease or even absent for newer drugs. Therefore, it is necessary to have a rational approach while prescribing to each and every patient with kidney disease. So, now what is this rational approach? This requires methods to assess the kidney function and some basic knowledge about the pharmacokinetic principles. Now, what is pharmacokinetics? It is the effect of the body on the drug, and it reflects the physiological process, that is the absorption of the drug, distribution, metabolism, and excretion. A short form to remember this is ADNI. And each of these processes can be altered in kidney disease. The concentration time profile of the drug reflects the net effects of the pharmacokinetics. And when I say time profile, what do I mean? Let's look at this much more in detail. This is the concentration time graph that we all should be aware of. This is initially you will see the absorption phase, and then we see the Cmax. It is the highest concentration seen, and this occurs at a time known as the Tmax. And then it decreases over time. The rate of elimination is defined by the elimination half-life, which is the time it takes for the drug concentration to decrease to half. These are very important principles, so I will be referring to them time and again during this presentation. Now, when we take a drug orally, it gets absorbed in the intestine, goes to the liver, gets metabolized in the liver, and gets excreted in the bile through the feces, or it may undergo intrahepatic recirculation. Also, after metabolism in the liver, it can enter the bloodstream as well and reach the target tissues. When it reaches the target tissues, we will have either the effect of the drug or the side effect of the drug. Following that, the drug is cleared by the kidneys. So, when we talk about pharmacokinetics of a drug, it is very important for us to know these four terminologies, that is the drug bioavailability, volume of distribution, T half or the half life of the drug, and clearance of the drug. Now, let's look into this in detail. What is bioavailability? It is the fraction of the drug which reaches the systemic circulation unchanged. And when we give an IV route, the bioavailability of the drug is 100%. And the symbol for bioavailability is F. The amount of drug that reaches the target organ will ultimately define our therapeutic effect. So, when a patient takes a drug orally, a part of it gets destroyed in the gut, a part of it is not absorbed, a part of it gets destroyed by the gut wall, a part of it is metabolized or destroyed by the liver, and finally, some amount of drug enters the systemic circulation. So, what percentage of this drug enters the systemic circulation is the bioavailability of that particular drug. So it is calculated by the formula of area under the curve of oral ingestion divided by area under the curve of injected drug. So we know that area under the curve for injected drug is taken as 100% or 1. And the Cmax, the concentration maximum of oral is always lesser than the concentration maximum of the IV injected drug. So this is how we calculate the bioavailability. Coming to volume of distribution, this gives information on how extensively the drug gets distributed to rest of the body compartment compared to the plasma. The plasma is the intravascular compartment, and volume of distribution is very important for us because we use this to calculate the loading dose of the drug. And higher volume of distribution, drugs have a longer duration of action. In chronic kidney disease, because of fluid overload, patients tend to have a higher volume of distribution. So we can see here that drugs which have high volume of distribution are smaller in size, lipophilic, and are bound to the tissue proteins. Drugs with smaller volume of distribution are larger in size, they are charged, and they are bound to the albumin, so they are restricted in the intravascular space in the plasma. So how do we calculate loading dose? Loading dose is calculated as volume of distribution into target plasma concentration divided by F, that is the bioavailability of the drug. Coming to volume of distribution, in an average patient, we know that plasma volume is around 4 liters, interstitial fluid is 10 liters, and intracellular fluid is 28 liters. Supposing we inject 100 micrograms of drug X, and then we check the plasma and we see 4 micrograms per liter of drug concentration. Volume of distribution is calculated as amount of drug in the body, that is 100 micrograms, divided by concentration of drug in the plasma, that is 4 micrograms per liter, that would be 25 liters. So this drug has a very high volume of distribution, more than the plasma. So obviously it is in the interstitial fluid or the intracellular fluid, and it has a very large volume of distribution. So what is drug clearance? Clearance of the drug from the systemic circulation is called as drug clearance. It is equal to hepatic clearance, renal clearance, and clearance because of the other reasons. Hepatic clearance, we have already discussed, the liver metabolizes the drug and excretes it in the urine or the bile. Coming to renal clearance, the kidneys filter the drugs either unchanged or the metabolites into the bladder. Increase in blood flow of the kidneys will increase the clearance. If there is renal failure, there is decreased ability to filter the drugs and the clearance gets reduced. What is elimination half-life or T-half? It is the time required to eliminate half of the drug from the body. So it is important for us to know what is first order kinetics and zero order kinetics. Initially, the drug undergoes first order kinetics, that is a constant proportion or fraction or percentage of the drug is eliminated per unit time. Or in first order kinetics, there is no saturation of metabolic enzymes or carriers needed for renal excretion, and it is very less liable to accumulation and toxicity. So, this is what is preferred in chronic kidney disease. When we move to zero order kinetics, a constant amount of drug is eliminated per unit time. All the enzymes and carriers are saturated. There is accumulation, and eventually it leads to toxicity. So, this is what we want to prevent in chronic kidney disease. So T half is calculated as 0.693 into volume of distribution divided by clearance. So it is inversely proportional to clearance. A decrease in clearance, as in chronic kidney disease, will prolong the T half. Coming to steady state concentration. Steady state concentration is a situation in which the rate of drug administration is equal to the rate of drug elimination, so that the amount of drugs remain constant in the therapeutic range. So you can see here, y-axis shows the plasma concentration and x-axis shows the time. Initially, to reach the steady state concentration, we need 4 to 5 half-life times of the drug. MEC is the minimum effective concentration. Below this, the drug does not have any effect. And MTC is the maximum toxicity concentration. Beyond this, the drug will become toxic. So what we need is the therapeutic range, which is between MEC and MTC. And this is your steady state concentration. So steady state concentration is calculated as dose into bioavailability divided by dosing interval and clearance. So how do we calculate the loading dose? Loading dose compensates for volume of distribution. It takes about 4 to 5 half-lives to achieve a steady state concentration, as I already mentioned. This is acceptable for drugs with short half-life. However, if drugs have a longer half-life, for example, amiodarone, it has a half-life of 110 days. So it is practically not feasible for anyone to wait for 440 days or 4 to 5 half-lives to achieve a steady state concentration. So in such situations, we need to administer a one-time loading dose to prime the patient. So this is the concept of loading dose. The goal of loading dose is to reach the steady state concentration in a very short period of time. And this is calculated as volume of distribution into steady state concentration divided by the bioavailability. So this is how we calculate maintenance dose. It is calculated as dosing rate, which is clearance into steady state concentration divided by bioavailability multiplied by the dosing interval. So please note here, maintenance dose depends on the clearance, while the loading dose compensates for the volume of distribution, and maintenance dose compensates for the clearance. So this is therapeutic index of the drug. Therapeutic index is nothing but minimum toxic dose divided by minimum effective dose. Drugs with wide therapeutic range are always safer in kidney. Drugs with narrow therapeutic range like digoxin, lithium, phenytoin, theophylline, warfarin, it is better to avoid these drugs in patients with CKD. So these are the three patterns whereby drug clearance varies by GFR. This graph shows as GFR decreases from normal to zero, there are changes in drug clearance. So if you start with drug B, for example, the red line, we can see that they are directly proportional. When you've got no kidney function, you've got no drug clearance. So this drug is cleared entirely by the kidneys. Examples would be antibiotics like beta-lactam and anticoagulants like dabigatran. If you look at drug C, no matter how the GFR changes, there is no effect on the drug clearance. This drug is entirely cleared by extrarenal routes, such as the liver mainly. Examples for a drug C would be antibiotic like macrolide and anticoagulants like warfarin. While drug A has a part of renal metabolism, renal excretion, and a part of hepatic clearance as well. Example for drug A would be quinolones and rivaroxaban. So, what are the principles of dose adjustment in chronic kidney disease patients? First is we have to consider the therapeutic target. What is the therapeutic target concentration that we want for a particular drug? We have to calculate the loading dose that is required, and what is the maintenance dose that is required, and the frequency. And when should we consider dose adjustment? Also, we have to look if there's any possibility to conduct therapeutic drug monitoring that would be very helpful in patients with CKD and patients who are on dialysis. Next is for us to look out for any published pharmacokinetic data from comparable patient population, that is CKD population or dialysis population, which is actually lacking in high rates. And also the inter-patient pharmacokinetic variability because of the pharmacogenetics always adds some degree of uncertainty to some of our predictions. So I'm repeating this time and again. Maintenance dose largely depends on the clearance of the drug. Drug clearance varies widely in patients with impaired kidney function depending on what their kidney function is, ranging from CKD stage 1 to 5. The decrease in drug clearance with impaired kidney function forms either a decrease in the maintenance dose, maybe we give a lesser milligrams, or we increase the dosing interval. So, which option, whether we decrease the dose or increase the dosing interval, depends on the toxicity profile of the drug, whereby giving higher doses less frequently may predispose to some toxicity. On the other hand, if you're giving less frequent doses, it improves compliance with our patient. So, when we have change in the pharmacokinetic, patients can have different time concentration profile. So, the black line shows what is happening in normal pharmacokinetics. If there is huffing of clearance in a drug that is taken orally, we can see what happens with the red line. There is slightly higher concentration and it persists for a longer time. In contrast, if you see doubling of volume of distribution, we get what we see in the blue line, where the concentration maximum won't be as high because there is a relative dilution and it has got more volume to distribute across, and the half life of elimination is long. So let's see how this impacts on therapeutics. Red line shows the halving of clearance, and we can see that there is accumulation and it occurs rapidly. The concentrations go up. This happens if we do not change the dosing regimen in the context of impaired clearance, that is impaired kidney function. In contrast, in doubling of volume of distribution, we get a lower concentration, but again, we do get accumulation to the point that it could cause toxicity, but it takes longer to occur than we see with the halving of clearance. So, both these conditions may be occurring in patients with chronic kidney disease, and we have to be careful with dose adjustment. So you can see here that if you prescribe gentamicin in patients with chronic kidney disease, this is just an example, without any dose adjustment, we will get accumulation of the drug as seen in the red line. So we can, what we can do is we can address this by doing two things. We know that the efficacy of gentamicin depends on how high the concentration is. So we know that we should not be decreasing the dose, otherwise the efficacy would come down. So what we should do instead is increase the dosing frequency. So when we do this every second day, we see that there is less accumulation, but still there is accumulation. And if we go to third daily dosing, we see even much lesser accumulation. So here, by simply by prolonging the dosing interval, we can decrease the toxicity of gentamicin. Coming to the impact of CKD on pharmacokinetics, absorption. So absorption is variable. Common thought is that there is gut edema, so the absorption might be reduced, but animal and human studies have shown otherwise. They've shown that drug absorption may be increased. So why? This is because of the uremic toxins and the edema. The enterocytes are disrupted. The tight junctions between the cells are disrupted. There's paracellular leak of the drug, and because of which the absorption of the drug is increased. The pH of the gut is more alkaline because urea gets converted to ammonia and pH becomes more alkaline. There is decreased in cytochrome activity. Expression of the cytochrome enzymes is decreased. There is reduced influx pump, which takes the drug into inside the enterocyte. So those pumps are all reduced, and there is reduced activity of the efflux pump. That is, these are the pumps which help in throwing the drug out of the enterocyte. So there is so this these pumps, that is the organic anion transporter pump and the P glycoproteins, are reduced in number, and also there is gut dysbiosis. Coming to volume of distribution, this varies with body mass and composition depending on the percentage of muscle mass and adipose tissue. It increases in advanced CKD because of hypoalbuminemia, fluid retention, and decreased protein binding. There is higher volume of distribution. And also, there is sarcopenia in advanced chronic kidney disease. In such situations, volume of distribution might be reduced, so it is inconsistent. You cannot generalize whether volume of distribution is increased or decreased to all CKD patients. So it is like patient to patient basis. And fluid overload affects volume of distribution of hydrophilic drugs more than lipophilic drugs. So you can see here that albumin binds weakly to acidic drug, and in CKD and dialysis patients there is hypoalbuminemia, so there is less binding to the drug and higher concentration of free drug level. Also, uremic toxins, they displace the drugs from the protein binding sites and they themselves go and attach to the protein binding sites, so there is higher free drug concentration. Now, how do we quantify GFR? So there are multiple methods. One is the serum creatinine based method, which is most commonly used. Next is the measured GFR, which is the gold standard, and it is usually done for research purposes using iohexol. Earlier, it was inulin. That procedure was more cumbersome. Next is the serum cystatin C based equation, but cystatin C is not based test is not widely available. So when we look at serum creatinine based equations, there are four of them, and we can use any one of them. There is no consensus or data telling that one equation is better than the other. Creatinine clearance is based on 24-hour urine collection. It gives in ml per minute. The remaining are all calculations Cockcroft called CKD, EPI, and MDRD. What we frequently use is CKD EPI equation, which is available from National Kidney Foundation app based on serum creatinine levels. So you can see that no matter which equation you use, it is going to be incorrect and it is not going to be equal to the measured GFR. The measured GFR is the gold standard and it is the straight line. And you can see that the estimated GFR is all over the place. The scattered dots, you can see it ranges from plus 30 to minus 30 to the measured GFR. So this is the National Kidney Foundation eGFR calculator I was talking to you about. So if you're using creatinine clearance or eGFR, you have to keep in mind that in case of obese patients, creatinine clearance would overestimate GFR and hence you have to use adjusted ideal body weight. And if you're using estimated GFR equation, you should know that it underestimates GFR in obese patients and you have to use de-indexed eGFR. So here, let's look at the effect of non-renal clearance with decrease in GFR, basically the clearance from the liver and the intestine. So here y-axis shows the non-renal clearance, that is the metabolic clearance, and x-axis shows the GFR. This graph shows a decrease in non-renal clearance in patients with reduced renal clearance for a whole range of drugs that can be seen here. Each of these drugs are chosen because they are probes for different enzymes. Example, theophylline is a probe for cytochrome P450, 1A2, rosiglitazone is a probe for 2 cytochrome 8, bosentan 2C9, omeprazole 2C19, midazolam 3A4, and so on. We can also see here that not all cytochrome enzymes decrease to the same level. For example, omeprazole has decreased to 25%, which is approved for 2C19, with a drop in GFR, while rosiglitazone, that is the green one, has decreased to only 50%. So there's a lot of variability. Also, not all drugs metabolized by cytochrome will change to the same extent. We cannot predict this. Why does this happen? So you can see here how hemodialysis influences hepatic clearance. So you can see erythromycin breath test immediately prior to and 4 hours after dialysis. So prior to dialysis, the metabolism or metabolic rate of erythromycin is lesser compared to post dialysis. Post dialysis, the uremic toxins are removed and the metabolism of erythromycin is increased, and so you have the percentage dose exhaled is more post dialysis. So circulating uremic toxins inhibit the cytochrome enzymes and impact them on drug clearance. So perhaps with higher levels of uremic toxins, we have severe inhibition of these enzymes. That's what we are seeing here. As the kidney function deteriorates, the percentage of metabolic clearance also decreases more and more because of the accumulation of uremic toxins, which is much higher in lesser GFR. So this is about enzymes. Now let's look at drug transporters. Fexofenadine is not metabolized, but it is a substrate for transporters, P-glycoprotein and organic anion transporters. They're active transporters. So you can see here that concentration maximum, T max, area under the curve, and T half has increased in end-stage kidney disease patients compared to control, while the drug clearance has decreased. This means that there is an increase in absorption, probably because the efflux transporters are not working very well in end-stage kidney disease patients. These efflux transporters are inhibited by uremic toxins. So, to further prove the fact that uremic toxins are inhibited, these transporters and enzymes were incubated in rat hepatocytes and rat enterocytes with human end-stage kidney disease plasma and looked for it. You can see that organic anion transporters, P-glycoprotein, and cytochrome expression has been reduced in end-stage kidney disease plasma. So, how does this mechanism act? So briefly, after oral administration of a drug, you can see the green circle D, that is the drug. It comes into contact with the enterocytes, which is lining the lumen of the gut wall, where it may diffuse or undergo active organic anion transporter mediated uptake across the apical membrane into the enterocyte. That is the purple cylinder that you can see. That is usually followed by cytochrome mediated metabolism, and subsequently the parent drug and the metabolite, that is the orange square, may be either actively counter-transported or effluxed via the P-glycoprotein, the green color cylinders that you see, back across into the apical membrane into the gut lumen, or be fecally extruded. Or it can get translocated across the basolateral membrane into the portal circulation. Once in the portal circulation, the drugs and the metabolites may either diffuse or undergo OATP mediated uptake across the sinusoidal membrane of the hepatocyte, again followed by cytochrome mediated metabolism, then diffusion or P-glycoprotein mediated efflux across the apical membrane into the bile for excretion. So MRP2 and the bile salt export pump may also be involved in biliary excretion. So you can see here that there is decreased hepatic expression of phase 1 and phase 2 metabolizing drug metabolizing enzymes. Also, if there is presence of drug metabolizing enzymes, the uremic solutes come in between and bind to it and prevent the drug from binding it. The role of P-glycoprotein. P-glycoprotein is the efflux pump. It is ATP mediated and it is protective. It pumps the drug out of the cells, preventing blood absorption, but the expression of P-glycoprotein is reduced in chronic kidney disease. The etiology of kidney disease also plays an important role. For example, if you look at ampicillin and cephalexin, it is the metabolism of these drugs is 25% lower in those with tubular dysfunction compared to those with glomerulonephritis, even if the GFR is same. So this is you can see here. There is active drug secretion in PCT and active drug reabsorption in the distal tubule after filtration. So we compare three drugs, benzyl penicillin. It is 50 to 70% secreted in the proximal tubule. So if there is tubular dysfunction, this will impact the secretion. Same applies for metformin as well. So we have very high total clearance for benzyl penicillin and metformin because of the active secretion in PCT. Even though these drugs are totally cleared by the kidney, so tubular damage may impact clearance and does not relate to the intact nephron hypothesis. Fluconazole has active reabsorption, so we have to reduce the dose to a certain extent. Coming to dose adjustments in patients with CKD, it is based on the change in concentration time profile of the drug of interest compared to patients with no kidney disease. If you look at patients receiving oral dihydrocodeine, there was an increase in area under the curve by 70% and Cmax by 29%. So, if there is an increase in area under the curve by more than 50%, then we increase the dose interval between the dose frequency. And if the concentration maximum increases by more than 50%, then we reduce the dose. So, here it is better to increase the dosing frequency. Whereas if you look at rapaglinide, here area under the curve and Cmax both are increased. Area under the curve has increased by 232% and Cmax has increased by 82%. So it is best that we reduce the dose as well as increase the dosing frequency. Now coming to dialysis, how does dialysis impact pharmacokinetics of the drug? Smaller molecules are better dialyzed. Protein binding drugs that are extensively bound to protein stay in the intravascular compartment. These are the drugs with smaller volume of distribution. These kinds of drugs have better dialysability. Also, it depends on the pore size of the dialysis membrane, the surface area of the dialysis membrane, and the geometry. Increase in blood and dialyzed flow rates will also increase the clearance of the drugs. So, why is all of this important? There are unpredictable changes in pharmacokinetics in chronic kidney disease depending on the drug dose and the severity of kidney disease, which can vary widely. Also, there is limited data. More drug trials are required in patients with kidney disease. FDA approval does not require data on patients with kidney disease. That's why a lot of pharmacokinetic data of drugs in CKD patients is lacking. These factors are not considered by clinicians or people who are making guidelines for drug dosing. So while prescribing to patients with chronic kidney disease, what do we do? So the purpose is to reduce subtherapeutic or supratherapeutic effect. So common is to use a conservative approach, start low and go slow. And depending on the rate of dose escalation, target will be achieved. So if it is blood pressure, HbA1c, monitor the target and go slow. Slow and conservative approach is less useful where rapid onset of action is required. For example, if you want to institute antibiotics or immunosuppressives, you can't slow and go low. But so this is where therapeutic drug monitoring becomes very important. This figure summarizes what happens in CKD and dialysis patients. So, the pharmacokinetics of the drug absorption, there is increased in absorption because of the paracellular reek, decreased efflux transporter activity, decreased P450 activity, distribution, volume of distribution of free drug concentration is increased, mediated by decrease in albumin and the uremic toxin, decrease in phase 1 and phase 2 metabolism, decrease in renal drug excretion, decrease in biliary drug excretion, and dialytic drug clearance leading to decreased plasma concentration. And after dialysis, there is normalization of non-renal drug clearance pathways. So conclusion changes are documented for all the four parameters, that is ADME. Changes vary between patients, drugs, and severity of chronic kidney disease. More data are required to better define these changes, and careful dose adjustment may be required. These relationships only apply at steady state, that is, chronic scenario does not apply to acute kidney injury where creatinine change is very dynamic. So you can just look up into this CJASN series where of introduction to nepropharmacology for the clinician, wherein you can see the difference in pharmacokinetic parameters for AKI, CKD, and patients who are on dialysis. And there are some suggested resources for drug dosing in dialysis as well. You don't have to by heart the pharmacokinetics of each and every drug. You can just look it up. Thank you. You can find me on Twitter at Mythri.